Hi, my name's Jo Gibson and I'm a clinical physiotherapy specialist working at the Liverpool Upper Limb Unit in Liverpool in the UK and also a consultant in private practice. If you haven't already accessed our free webinars about the stiff shoulder, I'm delighted to say that they're still available at clinicaledge.co/stiff shoulder. So if you've not had an opportunity to watch those yet, then please do. Loads of information, up-to-date research, and importantly, some key clinical tips and tricks of things that might give you best value in your treatment. Now, for tonight, I'm going to kind of continue our case study theme and just talk to you about a really interesting patient that I saw just before Christmas that just raises some interesting things about diagnosis and some specific considerations in the skeletally immature individual. So the girl I saw was a 14-year-old swimmer. She'd swum since the age of 8. She was obviously very good at what she did. She'd had a bit of a growth spurt in the previous 12 months, but she came to see me with a 6-month history of shoulder pain. She described it as superior shoulder pain with some radiation down into the front of her shoulder. And basically, if she did her training and her associated weight training, her shoulder got really, really sore to the point that she was struggling to sleep on that side at night. It was starting to cause problems through range of movement, and she'd been to see a physiotherapist. Now, the physiotherapist had done all sorts of what sounded like good shoulder rehab in terms of cuff and scapular work and some strengthening, but actually all it seemed to do is make her symptoms worse, so she got a bit disillusioned. All the way through this, she's carried on training. She's knocked off the weight training a little bit that she was doing as land-based stuff with her squad, but essentially she's never had a complete rest from what she was doing. So she comes to me, she's a little bit fed up. She's lax in her shoulders in that she has over 95 degrees of external rotation in neutral and in abduction, but she isn't generally hypermobile. So on a Baton scale, she doesn't have, she only scores like 2 out of 9. So there's no major considerations there. Now, as I say, she'd had this growth spurt. She seems to be really into her swimming. She's had some exams and stuff, but obviously swimming's a bit of an issue because of what's been happening with COVID. So she's actually at a point where she's probably going to have an enforced rest because she can't actually get into the pool. So what are the things that are going through my head with an athlete that comes with this sort of history? Well, you may be forgiven. The first diagnosis that might come into your head might be distal clavicular osteolysis. She tells us she's got very superior pain. It's definitely worse when she reaches across her chest, and if we do cross adduction, she's got some end range discomfort, and there's absolutely no doubt that she's indicating the superior part of her arm. Now, if you look at the evidence for distal clavicular osteolysis, which basically is resorption of the lateral end of clavicle, it's a stress response. There are 2 key types, a traumatic and an atraumatic. Now, this girl, clearly, she has no clear history of trauma. She just says it came on gradually and then started to get provoked by her training and by her weight training. Now, if you X-ray somebody like this, what you'll see is the end of the collarbone looks a little bit like a black hole because there's this stress response, like a microfracture response, that results in resorption of that bone. Now, the thing that's really interesting is there's definitely some really nice case series looking at the relevance of this in somebody who does regular overhead sport. So if you look, there was a really nice study of over 1,400 young athletes between 13 and 19 with shoulder pain, and they found an instance of 6.5% of this distal clavicular osteolysis. Now, the thing that was really interesting is, one, it was highly associated with growth spurts, highly associated with glenohumeral joint laxity, and also with supplementary weight training. So they looked at this whole series, and 74% of this 6.5% of patients with a distal clavicular osteolysis, essentially the common theme was that they were doing repetitive loading with supplementary weight training, and that kind of seemed to be the deal breaker. Now, of the rest of them, they were represented by sports like soccer, goalkeepers. That was one of the most common things. Now, the other thing that's really important to know, so in this study, what they essentially did was look at them over a long period of time. Now, the good news is that 93% of that cohort responded to conservative management, which essentially was modifying their strength training, modifying their training load, and actually having a rest for a period of time, but then getting back to the things they wanted to do. Now, with that approach, and on average about a 3-month intervention, 93% had a good outcome. However, what was really interesting is they followed up all these athletes over a 5-year period, and they had a control group that hadn't had the distal clavicular osteolysis, so an asymptomatic group. Now, what they found when they followed those patients up over time is the ones who'd had that episode of distal clavicular osteolysis, 71% of them 5 years later, so remember this was a 13 to 19-year-old age group, had clear signs of osteoarthritis on the AC joint, compared to 35% in the control group. Now, what's of those 71% that had finding of osteoarthritis on the AC joint, only 40% of those were symptomatic. But that's really interesting that that initial injury seemed to have some relevance in the longer term in terms of symptomology. Now, of course, there's probably lots of variable factors in terms of where they were from a developmental point of view, what they were doing still sports-wise. But again, what's interesting, those that had stopped sport, there was a smaller instance of osteoarthritis. So again, there seems to be some kind of theme here in terms of those growth spurts, that associated supplementary weight training, and if you like, just continuing and not giving a proper rest to let that system recover. Now, if you do an MRI of these people, what you'll see is you'll see edema in the distal clavicle in the bone marrow, and you'll also see subchondral cysts, and you can actually sometimes see those cysts actually on the X-ray. If it's a severe case, and interesting, this is a pathology where this pain often correlates with the imaging in terms of the severity. You can see a reaction in the periosteum, so like a periostitis. But obviously imaging is very important in this group, particularly when you've had that long history, because you need that, if you like, to be able to convince the athlete that they need to genuinely have a break. Now, that's maybe the most obvious thing, and remember that was 6.5% of over 1,400 patients, but there's another thing that's really important for us to consider in this particular age group. I'm sure many of you are aware that when you're born, your acromion is all cartilage, and then you have these ossifications and these apophysis, if you like, these growth plates that actually then, if you like, start to develop the bone. Now, there's anywhere between 2 and 5 in the acromion. The most common 3 that are described are the preacromion, which is usually this anterior part, the mesoacromion, which is this middle part, and then the metacromion, which is this third part. Now, why am I telling you that? Because in between 1 and 15% of the population, more common in African Americans, then actually those things never fuse, and you're left with what's called an acromiale. So often you'll find patients come with shoulder pain in later life as adults. They have an X-ray for whatever their other problem is, and they pick up an acromiale. Now, there's some belief that this gives you a higher risk of developing rotator cuff tears. I'm not convinced that that's well supported. There's other factors that make that more relevant. However, what's important in this young lady is at the age of 14, essentially these things won't be fused, okay? And actually the cartilage in those apophyseal areas is actually relatively weak compared to those other surrounding structures. So if you like, you've got this really thick periosteal sleeve, you've got deltoid and trapezius attaching on there, so you've got the really strong pull of traction, if you like, of those muscle attachments. And also you've got your AC and your coracoclavicular ligaments. So potentially there's a lot of stress around the area. Now, another study, again, that looked at a big number of athletes doing overhead sport found an instance of 2.6% of this acromial apophysitis, as it was called in that study. Now, later authors have suggested that we actually should call it apophylysis. I'm not even sure I could pronounce that this time of the evening, but more like the distal clavicular osteolysis, actually looking at it like an apophylysis rather than true inflammation, because generally it's actually demonstrated in patients related to overuse. Now, again, there's some quite interesting things in terms of those people that might be more at risk. Again, our overhead sporting population, absolutely no doubt whatsoever. Again, in association with a big growth spurt, and again, in associated with weight training, these things seem to have some relevance. So it's really a question of which end of the joint cops for it, if you like. Now, the thing that's really interesting is if you actually look at this apophysiolysis or this apophysitis in the acromion, The issue is if athletes stop doing the provoking activity, often their symptoms will actually improve very, very quickly. The problem is they need a good period of time to actually recover. So very commonly what will happen is they get some superior shoulder pain, they have a rest, it feels loads better, they go back to training and the same thing happens again. Very similar with osteolysis of the clavicle, but the key thing with osteolysis of the clavicle is it's often more specific in terms of things like bench pressing and shoulder pressing, very specific movements that stress the AC joint. Now, again, you can see why imaging is going to be so helpful. What an X-ray will do, particularly an axillary view in this acromial apophylysis, will show you that those growth plates are unfused. Well, in a 14-year-old girl, that's not terribly surprising. That's around the age that they start to fuse. But those in the acromium, those growth plates often don't fully fuse. The apophyses don't change or fuse until your early 20s. So again, that's something to be aware of, because they sometimes get misdiagnosed as a fracture when actually it is just an unfused growth plate. Now, as I say, the most important thing is athletes are actually given a sufficient time to rest. Now, obviously, this is another time when MR is really useful. If you do MR, what it will do is help differentiate between those two groups, because essentially it will show that the edema is in the apophysis in the acromium rather than affecting that lateral clavicle. So it's a time when imaging really is helpful in terms of your diagnosis. Now, remember, I met this girl 6 months down the line and she'd had what sounded like good physio, but the thing that was missing was actually having a proper period where she'd unloaded that system. Now, why is that important? Well, remember, I said in the lateral distal clavicular osteolysis that essentially when you follow those patients up over time, they have a high chance of developing osteoarthritis as a secondary phenomenon, and about 40% will have some symptoms related to that. So what happens in this acromial group? What are the potential risks of that? Well, interestingly, the risk is that they develop an osteochromiale. Well, they don't develop, they're just left with unfused apophysis. So again, when they followed up this big group of patients, what they found is 86% of them had osteochromiale. So that early instance of pain associated with sport in these adolescent years predisposed them that those apophyses didn't fuse in the longer term. Now, when they followed them up over the age of 25, what they also found is there was a higher association with rotator cuff tears. Now, we have to be a little bit careful, because in this cohort, if they were still doing high-level activity or regular sport, the fact is we know that anybody over the age of 20 who's done sport from a young age, if you want to find something, then do a scan, because there'll be something because of the repeated loading on the joint. So what's not clear from the study is how many of those people were symptomatic, and we know how careful we have to be putting too much store by imaging, particularly when it relates to the rotator cuff, and particularly in the absence of a key acute injury that resulted in functional loss. However, again, very like the osteoarthritis of the AC joint, in this group, that osteochromiale definitely seems to be significant. Now, what was interesting is in the group that had this instance of this acromial apophysitis or apophylysis, who actually then stopped their sport and were still followed up in the same time span, then only 50% of those had an osteochromiale. So stopping the sport actually minimised the risk of having that. Now, is the osteochromiale an issue? No, it isn't. If it's stable and everything's in line and you don't have any instability there, then actually the evidence would suggest there is no increased risk of having any problems. And the issue is that often, because it became associated with cuff tears and impingements, when we used to call it that, there was a lot of overzealous surgery in trying to stabilize these things. There is some evidence that in patients who have trauma with a pre-existing osteochromiale that then makes it unstable, or those where there's a step deformity, so potentially an adaptation after loading it at a young age, then that may relatively increase your risk. But it's a perfect example of how important it is to take into account the whole history. So in terms of clinical testing, what gives you best value? Well, one, this gives a great illustration of how the AC joint and any of those structures around the acromium can refer pain into the lateral cervical spine or down into the front of the shoulder. But generally, AC joint pathology will be local What I'm trying to say, it'll be tender locally if you've got a history of overload or whatever. But again, this girl was very tender, more on the tip of her acromion. Now, I have to be honest saying that to you, because if you look at studies around palpation accuracy of the AC joint, it's as low as 16% in some studies using injection into the joint to assess palpation accuracy. It's as high as 50% in studies looking at orthopedic registrars. Now, again, we have to always put things together, but if you've got local tenderness which is reproduced by some sort of stress test, your cross adduction, your resisted extension test, your O'Brien's active compression, with that relevant history and provoking movements that are consistent, then again, in that young cohort, these are the things that we need to talk about. So we sent this lady for an MR scan, and it turned out that she did have an acromial apophylysis. So essentially, she had a traction or a stress response in that apophysis. So she needed to have a break. She could still do all her kind of switch on foundation exercises, make sure her cuff function was good. But what she needed to stop was doing heavy loading and massively reduce her training volume. So she could do some gentle work, but importantly, she needed to give that system time to respond. How do you test that it's recovered? You can repeat your MR, you can do your X-ray, but the important thing is the evidence is pretty clear that on average, it takes a minimum of 3 months. So I guess the key message, particularly in this acromial apophylysis group, is that don't take lack of symptoms and lack of palpation tenderness as sufficient. If you've got an MR, they need a period of time to recover. Exactly the same with your clavicular osteolysis. Again, they may stop being symptomatic in terms of local palpation and stress tests quite quickly. But again, in terms of giving that system a chance to remodel, it would appear to take 12 weeks in most patients. And then when you introduce load, clearly you're going to want to do that carefully. Remember, the biggest risk factors were growth spurts, a background of glenohumeral joint laxity, but also that supplementary weight training and training load. So as ever, load management seems to be really important. So she's a really interesting case and just something to share with you. Now, guys, I can see all sorts of things in the comment box here, so I'll get to your questions. Catherine asks, can you get slipped epiphysis in shoulders? You can in the proximal humeral epiphysis for sure. We'll maybe talk about some traumatic injuries in younger athletes next week, specifically around the acromion and talking about growth plates. That might be a nice thing to talk about. Salter-Harris fractures and things like that, which involve the growth plate. And I'll get some evidence together for you, Catherine, about that group specifically. So thank you very much for that question. Lisa, you have an acromiale that took ages to get diagnosed. So again, Lisa, the key thing is that can just be a normal anomaly for you. The important thing is there a step deformity? Have you fallen on it to make that provocative? That as a standalone thing doesn't necessarily mean it's a cause of your shoulder pain. So that's why this is so important, and thanks for sharing, because it's kind of looking at where that fits with your overall presentation. How do we decide return to play for sport? Oh, that's a great question, and thanks for an interesting case study. So I'm so sorry, I can't pronounce your name. I'm sorry, that's so rubbish. I apologize. In terms of return to play, what I would say is the key thing, first of all, is these athletes are told that they can't do their full training volume from a minimum of 3 months. For me, I always use measures of cuff function and then essentially build up their training volume as I need to then make sure they're withstanding it and we're not getting any response in terms of pain. So actually in both these types of injuries, pain is very useful when they start going back. For me, an absolute prerequisite is making sure that I've restored their ratios, their rotator cuff strength, that I've looked at potential contributors in the rest of the kinetic chain. But I think why your question is so important is in this group, time really is the most important thing. So for me, it's about modifying that training load for a 3-month period, re-imaging to make sure that things have recovered, and then building up very carefully. And to be honest, it's more about that than it is actually passing particular return to play tests. That would be very different in somebody who'd had a stabilization, had surgery, had a tear. then, I'm going to look more specifically at what that return to play might look like. And we've talked about that on a previous Facebook Live. But I think it's a really great question. So thank you, because really in this group, time is absolutely the most important thing. However, we can use that time to make sure we've got the foundations in terms of optimizing shoulder function, if you like, make sure that we've addressed any strength or power deficits elsewhere. And again, why it's a lovely question is, in these athletes, you can get very despondent looking at that period of time out. As it happened with this girl, she can't swim anyway at the moment because of COVID and the pools are closed. So actually, it was a great way to actually reflect it back and go, you know what, injury is a fantastic opportunity to actually look at making you an even better athlete when you can get back in the pool. So let's have a look at all the things we can improve. And so we look at her lower quadrant strength and power. We look at some endurance tests in her trunk, as well as looking at her shoulder function. So a real opportunity. Have you seen this in rock climbers, Nick? Absolutely. Young rock climbers for sure. But actually, in terms of mature athletes, if you look at the biggest causes of clavicular osteolysis, which is, I would definitely see in a skeletally mature population, one of the most common groups is weightlifters, particularly those who their one repetition max is 1.5 times their body weight or greater. That's a risk factor in itself. But certainly, again, rock climbers who increase their weight training and obviously are still doing their training load do have a risk of developing it. But again, you can get a post-traumatic osteolysis in both the skeletally immature and the skeletally mature groups, where you have some sort of impact injury or overstretch injury, most commonly impact injury. And again, you go back to loading too quickly, you have a high risk of developing an osteolysis. And again, the common theme is settles when they rest it, flares up as soon as they go back to loading again. So I've definitely seen it in that population. Lucy, what about distal clavicular osteolysis in adults, and loading is related to work? How long should they have off? So Lucy, this is a really interesting question, because it's like, how much load is too much load? Assuming their cuff and their shoulder is kind of strong enough to do what they need to do. Most studies about distal clavicular osteolysis kind of suggest it's heavy weight. So essentially, if they can modify what they're doing. So I guess if they're a manual worker, try and bring everything below 90 degrees by standing on a step and sort of minimize that higher range loading. What seems to be really provocative is above shoulder height and any kind of bench pressure or pushing type movement. So those would be the things that I prioritize in terms of modification, because we all know that a lot of people, particularly at the moment, taking time off work might not be an option. If they're in a work where they've got to have enforced rest, then fantastic, it's working for our advantage. But again, it's about modification, and keeping it below 90 degrees definitely seems to be one thing that makes a big difference. So Jane, yes, we've just, so as I say, osteolysis in adults, commonest thing I've seen is goalkeepers falling onto the point of the shoulder, going back to weights too soon. I've seen postmen carrying heavy bags. The most common mechanism has been some sort of trauma or suddenly increasing weights in the gym. And as I say, the common pattern is they rest it, it feels better. They go back to do it, it gets sore again. X-ray is invaluable in your differential diagnosis, because you will see that relative black hole, that reabsorption in the lateral end of clavicle. And that's so important, because again, they've got to stop heavy loading for that period of time. Debs, I've got a young 13-year-old badminton player with a similar history. Excellent. So maybe some imaging would be useful. Great. I'm glad I answered that question. Thank you, thank you, thank you. Lovely. So lots of thank yous. That's fabulous. So hopefully that was a really nice case study to start our new year journey back into all things shoulder. I'm going to mix it around with case studies, just some interesting developments in the research. But again, if there's key things you'd like us to talk about, please don't hesitate to get in contact. I think the great thing with some of these patients in these days where it's very easy that when patients have symptoms that persist for a long period of time, it all becomes about the psychosocial aspects. And of course, that's really important. But these really help signpost when we need to be vigilant for some very specific pathologies, and how the history, some risk factors, and also importantly, what it means to our management. And it really illustrates that sometimes imaging can be the game changer in terms of ruling in and confirming a diagnosis, and therefore helping set out our management plan. So guys, thanks so much for joining. Further to Catherine's question, we'll have a look at some of those particular traumatic injuries, if you like, next week, particularly in that younger group, and what the specific considerations might be, because there definitely are some things that we need to consider. Stephanie, one last question before I let you go. Is it possible that this young athlete was being pushed too hard by her coach, lifting heavy weight that was too much for her growing and developing body, and the coach needs to be involved in the rehab? Oh, Stephanie, what a fantastic question to finish on. So I deliberately didn't get too much into that because, as you picked up, one of the common themes was the combination of training load and that supplementary weight training. And as I'm sure you'll know, that weight training in the skeletally immature athlete is quite a contentious area. Of course, I don't have an issue with them doing strengthening, but what's really important about your question is how we make sure she's ready to do that, and what are the key foundations. So for me, there's some key functional tests I'll do in the shoulder before I want them to start loading up. But what I love about your comment is the importance of liaising with the coach. We're all in it together, and I don't want to see that I'm criticizing them, but I do want them to see how we make sure we get this athlete back and to stay back, so we minimize problems in the future. So thank you, that's a really important comment. In terms of, is it too much, too soon? Again, it's looking at that training load. There are things, in fact, there's some lovely work come out from Kevin Cummins about he's an absolutely fantastic guy specializing in shoulders, but really producing some fantastic work. I'll dig out some of the stats and stuff about training load and volume. But again, as I say, the important thing with load is making sure somebody's basically having sufficient recovery time, but also importantly, they've got the basic foundation of how to do it. Jane, osteolysis of the whole scapula? No, I haven't. That's a really interesting question. I shall put that on I'm just going to make a couple of notes now so I don't forget when I log off here. No, I haven't. It's a simple question. It's usually a stress response in a specific place that's loaded because of the activity. I'll have a look at the slipped epiphysis literature as well, and I will look at that volume stuff as well, and we'll look at those traumatic injuries next time. Guys, fabulous. Thanks so much for the interaction. Great to have all your questions. So guys, thank you so much for joining our shoulder session, our Facebook Live, and I really look forward to continue that journey. Now, Claire's just snuck one question in. I promise I'm going to go in a minute. 18-year-old male, 6-month post AC joint traumatic dislocation with osteolysis on Xray, rehabbing well, wishes to join the army, high-level gymnastics. When would you do more than rehab and look at surgical fix? I would only ever look at a surgical fix if rehab didn't get them there. The bottom line is, if you think of that original study I said in the distal osteolysis in young people, and he's represented by that group, the under 19, the 7% who went on to surgery were the ones who wouldn't stop, who wouldn't take a break. Now, I would argue that's not necessarily the best case for doing surgery, but that was and that's a nice numbers study. Generally, you would try an injection first, and again, that period of activity modification and then building up carefully. But surgery is, really the last resort. And essentially, they generally do an excision of the AC joint, which then stimulates a response. But arguably, particularly in somebody of this age group, if you can get there with the right advice and the time, and then make sure he's got all the ingredients there, you've got a really good chance. So guys, I'm really going now. I keep promising I'm going, and we get some more questions sneaked in. As I say, big challenges at the moment. Hopefully we're going to start seeing ourselves moving out of it. Keep safe, keep healthy, and join us next Monday for some more shoulder geeking and another Facebook Live. Thanks again for joining, and I'll see you all again soon. Bye for now.